So then only we can address the subsequent problem. There's no point if you repeat the same mistake, and in case you go for a second surgery, or in this case a revision surgery, and the revision surgery might fail.
I've torn my ACL 3 times in my life. I've had 2 different surgical techniques. The third tear, my worst one, I chose to leave untreated. Which brings me to today, to a very important conversation about not just orthopedics, but something that has been impacting my health for a very long time. My name is Kevin Cho. I'm the co-founder of Medifly, and this is the Medifly podcast. My guest today is Dr. Kow, consultant orthopedic and robotic joint surgeon at ALTY Orthopaedic Hospital in KL, one of Malaysia's first single specialty orthopedic hospitals. Dr. Kow has graduated as a top clinical specialist in the cohort with a master's in orthopedic surgery, and he's an active researcher with a growing body of published work on robotic joint surgery. He's been an editor at the Malaysian Orthopedic Journal, and from everything I have read from his public writing, he's one of the top surgeons and very rare surgeons who actually talks about what medicine costs, what a scan isn't need, when a scan is not needed, when technology actually helps versus when it is just marketing. So that's honestly why I wanted him to be on the show. And today we're going to be talking about, number 1, what actually separates a great orthopedic surgeon from a good one. Number 2, where robotic surgery genuinely changes outcomes and where it is overhyped. Number 3, what happens long-term to knees like mine, injured, repaired, and sometimes left alone. And the questions every single patient should be asking when they let a surgeon anywhere near their joints. So Dr. Kow, welcome to the show. Would you mind giving a quick introduction of yourself first?
Hi, hello. I'm Dr. Kow from ALTY Orthopaedic Hospital in Kuala Lumpur, Malaysia. I'm one of the robotic surgeons who specializes in hip and knee replacement surgeries. And I mainly treat patients with hip and knee joints problem as well as other joints problem. And my specialty is to help patients with knee problems such as cartilage problem, ligament problem, as well as muscle problems.
Yeah, thank you very much. First question I want to ask you is, most surgeons pick their specialty based on something personal. It's a mentor, a case, a moment. What pulled you specifically into joints and orthopedics?
Okay, so actually my experience is almost like yours, where I personally experienced orthopedic problem before. Actually, I have a fractured my tibia, which is the thigh bone before, during my teenage days. So that kind of like hooked me towards orthopedic. So since young, I'm a bit, I have some reading on it because me myself experienced that problem. And since then, I'm more interested to venture into this field. And that got me into the medical school in the first place. And in the medical school, I already have all this exposure to bone and joint diseases. And since graduating as a medical doctor, I further specializes in orthopedic, where I become one of the youngest surgeons, and also because of my mentors who specializes in arthroplasty, which is joint replacement, and that further enhances my interest in terms of this field. And this is how I end up as an arthroplasty surgeon.
So pretty much, from an injury that all started. So another question I have is, you are obviously very busy as doing your clinical practice, but you're still very deeply involved in research and journal editing. A lot of surgeons drop the academic stuff and when they go private. Is there a reason why you continue doing that?
Actually, I think that clinical practice is very important, but your clinical practice all boils down to the underlying knowledge behind it. So whenever you practice something, for example, when I'm doing a surgery, you need to have deep understanding in terms of the knowledge, in terms of the skills, as well as the know-how, and most importantly, the physiology and underlying diseases behind it before you address the underlying problem. So this is why I actively involved in academic in terms of teaching the undergraduate as well as those upcoming orthopedic surgeons, as well as actively involved in researchers, where I'm venturing myself into getting the knowledge as well as getting to know all the diseases, because what we are dealing with the diseases is only 20% of them are known. The other 80%, which is largely under surface, are still unknown. So there are still a lot of things unknown in medical fields, especially in orthopedics. So that's why I'm actively involved in researches where we get to know more about the diseases, and that is how we able to help our patient more.
Mm-hmm. Okay, and say if I am a patient that is coming in for knee or hip surgery, what is one question that I really should ask that often is overlooked?
So actually, it depends on the patient's profile. So if you're looking from a younger perspective, when we say young, that means it's 50 years and below, then we are looking at joint preserving surgeries. And if we are talking about patients with 50 years and above, which is considered elderly, then we are considering those for replacement surgeries. So these are two different profile of patients. For younger patients, mainly they are having ligament issues like yourself, and meniscus issues, and also cartilage issues. So when we examine the patients, we need to know what is the underlying problem behind that knee pain, because most of the patients come with a knee pain. So we need to know what causes the knee pain in the first place. And by addressing the underlying cause, then only we can address the problem at its root cause. And for elderly patients, 50 and above, then we are talking about the disease progression. At what stage they present with. So if it's a mild to moderate stage, so most of the time we try to do joint preserving alternative. But for those with very severe deformities that is affecting their activities of daily living, then we are talking about joint replacement surgeries.
So robotic surgery is marketed very, very frequently. Like if anyone has gotten off the plane from Penang or KL, they would see robotic surgery posters pretty much everywhere. And nowadays, if you go into every single hospital website, they have the big words robotic everywhere. So I want to ask you, a question. So cut through all the marketing, right? When does a robotic surgery genuinely change the outcome? And where is it honestly overhyped?
So actually, from my point of view as a surgeon, I think that robotic surgery definitely helps surgeons. But robotic surgery is actually a tool where it assists the surgeon, but not replacing the surgeons. It depends on how the surgeon uses the robotic system. So it's just like a knife for a surgeon. If you use it correctly, it can create a very good scar, and you can perform a perfect surgeries. But if you are not skilled enough, you might even cut the wrong things. So in that sense, robotics actually do help the surgeons and assist the surgeons, but it also provide a false narrative that the surgery will be perfect. So it all boils down to the person behind the robotic system, which is the surgeon itself. So if you know a surgeons who are experienced in it, then you might get a good outcome. If not, then it might actually give you a sense of hope.
How about yourself? How often do you do robotic versus like not? And in what situations would you be choosing robotic?
So for myself, I'm trained in robotic surgeries. So I uses multiple systems. In fact, I'm trained in 4 systems of robots, and that's how I know what are the pros and cons of each robot. And depending on the patient profile, I use different robots to help my patients. So obviously, when I'm using it a lot, actually I've done more than 300 cases on my own in terms of the surgeries using robotic systems. So that's how I gather my experience and help my patients.
Okay. And I have another question about ALTY. So ALTY is a very, very different hospital compared to everyone else. It's a single specialty hospital, which means, if I understand correctly, as I saw on your website, that means 8 orthopedic surgeons under one roof, with weekly multidisciplinary case reviews with all the different practice, like anesthesiologists, physios, cardiologists, and most private surgery happens in multi-specialty hospitals when surgeons are solo operators. From the patient side, what does that structural difference actually mean for patient outcomes?
Okay, so actually the single specialty hospital concept actually help our patients more, because if you look at it, our patients are mostly of the same demographic with the same kind of problem, and most of them, they undergone the same type of surgeries. So it helps in terms of our supporting staff to know them better in terms of the disease progression, as well as how to do their rehabilitation protocol. So for example, for a physiotherapist, in other hospital, they are being exposed to different kind of diseases. For example, heart disease, lung disease, abdominal problem, upper limb and lower limb, or hand and legs problem. So they need to know everything, but none of them, they are expert in certain field. Whereas for our hospital with a single specialty concept, our physiotherapists, they are trained to do that simple one task only, and which is to help orthopedic patients recover. So in that sense, our patients will get a specialized care, not only from the surgeons, but also from our supporting staff in terms of the nurses as well as the physiotherapists. And that really helps our patients in terms of their outcome.
So I want to get personal here. So my experience is I've torn my ACL and 3 times and my meniscus once. So it happened like 2017, once on my right leg, and in 2020 on my left. And the third time I tore it was just 2-3 years ago. Yeah, 2023 October specifically. So it's obviously, very, very painful to go through these surgeries. When would you recommend a patient to undergo surgery, and when would you recommend the patient not to do an ACL surgery?
So when we encounter problem like this, we are talking about revision surgeries. So first of all, I would like to identify what causes it to fail in the first place. So that is very important. You need to understand what causes the pitfall in the first place. So then only we can address the subsequent problem, because there's no point if you repeat the same mistake, and in case you go for a second surgery, or in this case a revision surgery, and the revision surgery might fail. So first of all, you need to understand what causes it to fail in the first place. Is it too fast in terms of the rehabilitation protocol? Is it because of the graft size that is inadequate? Or is it because the way of mechanical alignment is being adjusted that is being faulty? So these are all the factors that need to be addressed before we embark on the revision surgery. Okay, so after we have identified the underlying problem, then we talk about the subsequent solutions. So in your case, in a young patient like you, normally we try to preserve whatever native structure there is. In this case, the ligament, which is the anterior cruciate ligament, ACL. So why is it important? This is because ACL, in terms of the maintaining the knee stability. So when the ACL is ruptured, your knee lost the stability, and that causes the knee to be unstable. And when the knee is unstable, it causes two things. One, when it's moved about every time you walk or every time you run, it causes damages to the surrounding structures, and especially your meniscus as well as your cartilage. And over time, this degenerative tear or the degenerative problem can compound over time and causes early osteoartritis. And this is what we are trying to prevent in the first place. So in your case, first of all, we need to identify the underlying root cause. Second, we need to examine your condition, whether there are any associated injuries in the first place, and in this case, meniscus and cartilage. And thirdly, after we have examined clinically as well as perform an MRI to evaluate radiologically, then we'll talk about the treatment, which is revision surgery. So revision surgery, normally we'll do the ACL reconstruction, but in this case, it's not using your own graft, which is your own body tendon. This time we will use an allograft, where we harvest from normally the dead bodies to replace your ACL. And At the same time, we address whatever surrounding structures that are being damaged in the first place.
Oh, so the graft doesn't need to come from my own body. It could be coming from somewhere else.
Yes.
Can you explain that? Because for so long, I thought it was only from hamstring or my kneecap. I didn't know I can skip that part.
So actually ACL, when it's being ruptured, we normally do a reconstruction surgery. Reconstruction meaning we replace the ACL with something new. And in this case, we have a few graft options. So graft is something that we replace the ACL. And the graft can come from a few sources. One is the autograft, which is what we harvest from your own body. And the autograft can be from the patella tendon or from the hamstring tendon. Okay? And these are the autograft, which is from your own body. Second one is allograft. Yeah, so allograft is something that we harvest from other people's, in this case, dead bodies. And by using that graft, we replace whatever autograft cannot provide. And in this case, we already exhausted all the options, so we need to use allograft. There are another alternative, which is synthetic one. So in this case, it's a BioBrace. And BioBrace is normally used in combination with autograft. And in this case, we use it normally in patients where the graft size is inadequate. So just for your information, generally we wanted an 8 mm kind of a size of graft. So let's say when we harvest your own hamstring graft or patella tendon graft, we find that the size is inadequate. In that case, we'll add the BioBrace to increase the diameter of the graft size. Because if the graft size is inadequate, it runs the risk of failing. So that might be one of the cause that you have a failure of ACL reconstruction in the first place. So I hope that this addresses your question.
Yeah, absolutely. And say, for example, if I look 20, 30 years down the road, someone like me who has torn an ACL 3 times, left one untreated, what does my knee look like when I'm 55? At 55 or 65, like more importantly, is there anything I can do right now as a 32-year-old to change that trajectory? Or is it quite necessary for me to do a surgery?
Okay, so we need to look at from two perspectives. So the first one is when you have the first injury, so you already developed the risk factor. So the first injury is an insult to your knee. So whatever damages is being done, and subsequently when you undergo the surgery, irrespective of how perfect your surgery is, let's say you end up with a perfect condition, 100% return to sports, everything, the first insult itself, it runs the risk of you getting the osteoartritis in the later years, especially in the 50s.
What is osteoarthritis?
Osteoarthritis is actually a degeneration of the knee joint, where your cartilage has already worn off in terms of the cartilage on the thigh bone as well as the shin bone area. So this is very common in the elderly population, especially for those with age 55 and above. So up to 1/3 of them will develop osteoarthritis. And in your case, because of the initial insult, your risk of developing this is even higher. So that's the first perspective. So by performing the surgery, you are able to reduce the risk to a bare minimum. Okay, I'll bet now up to 0, but still we reduce the risk. But now, when you have another second insult in the case of ACL rupture, then your risks are being compounded. And if you left it untreated, so your knee becomes unstable. And just now we talked about unstable knee will cause damages to the surrounding structures, especially the meniscus as well as the cartilage. And your risk of developing osteoarthritis is even higher. So this is what we wanted to avoid. We want to delay the knee from getting into the osteoarthritic state as much as possible. Because when you reach that stage, especially stage 3 to stage 4, then we are talking about replacement surgery.
What are 3 questions that someone should be asking a orthopedic surgeon if they're doing a knee replacement or a hip replacement?
So the first thing I would like them to ask is whether there's any alternative. So a surgeon who doesn't offer any other alternative doesn't know the problem well. So you need to know what are the spectrum of treatment options. Okay, starting from non-surgical to minimally invasive up to the most invasive one. So when you know the spectrum, then only you can apply that to the patients depending on the stage of the disease. Okay. Secondly, you need to ask like what are the pro and cons of each. So this will be very important in terms of deciding which one, which surgeries or which treatment plans is the most suitable for that patient. Because at the end of the day, each patient is different depending on his or her medical conditions, his or her activity or level, and the expectation. So when you are able to assess this, and then only you can use the treatment plan on the patients. And thirdly, I would like to ask whether the surgeons has performed the similar procedure before, and whether there are any successful stories to share. So if you have personally done it many times, obviously there are a few case series or case examples that can show to the patient so that they know what to expect when they undergo the surgery.
I think a lot of doctors would say that they have done it before. Yeah. How do you tell between someone who has done it a lot before and is an expert versus someone who is, doing similar surgeries but not an expert in doing the particular surgery that the patient is looking for?
So this one we can get from two sources. The first one is obviously from internet. When you just type the name of that surgeon in, then if that surgeon is well known among the world and he or she is reputable among their fraternities, then obviously he or she is surgeons to be known as an expert. Okay. The second thing is when you do a consultation with the surgeon are able to show you his or her patients and how well they do it. So for example, when I'm doing my consultation, this is how I will consult my patient and show them. This is how I will show. So in ALTY Orthopaedic Hospital, this is how I do the surgery. And the alignment technique that I will do for my patients, and a few examples of how my patients perform after the surgery. So when you are able to show with the real life example, that gives the patients more confidence in undergoing these kind of surgeries.
So you have quite a lot of displays here. Is there anything you want to highlight here?
Okay, so when we talk about knee replacement, a lot of people, they only talk about total knee replacement. So this is total knee replacement where we replace the whole thigh bone and the shin bone. Okay, this one is indicated when the cartilage wear and tear or cartilage damages has already involved all compartments of the knee joint. Okay, actually a lot of people don't know that there are such what we call joint preserving surgeries where we replace only half of the knee joint. So this is the model of partial knee replacement where we replace only half of the knee joint, because when we do the surgery, actually we found that most of our patients, their cartilage wear is only located at the inner side of the knee joint, and the outer joint 90% of the time they remains intact. So if you do the total knee replacement, you are replacing the normal cartilage on the outer aspect. So why is it important to do partial knee replacement instead of a total knee replacement? This is because when we do a partial knee replacement, we are able to preserve all the ligaments, and the most important thing is to preserve the ACL. So by preserving the ACL and also the PCL, we are able to retain all the stability of the joint without sacrificing all the intact structures. So why a lot of patients don't know about this partial knee replacement is because even doctor itself, most of them, they don't know how to do this. So they'll just skip this treatment. They'll ask the patient to do injection multiple times on the knee joint until the knee joint becomes so severe that they will do the total knee replacement. So they skip this stage altogether because they don't know how to do. So this is one of the advantage of single specialty hospital, where all of our joint surgeons, they are specializing in joint replacement. They are able to do this partial knee replacement. And this is how we get the patient back to normal walking as soon as possible. In fact, those patients who have done partial knee replacement, 95% of them can walk within the same day or the next day.
I want to ask you a question about stem cells. So I've heard a lot of people doing surgeries and then going to Thailand or going to some other countries to do stem cells. So they inject stem cells in where they did their surgery, just hoping that they can get healed quicker. Do you have any opinions on doing that?
Yes, actually, so stem cells actually helps, but you need to know what is the underlying basis behind that. So for all the treatments, you need to know what is the underlying basis. So, and not just, okay, when the patient have pain, just prescribe medication without knowing what is the underlying issues behind it. So in this case, we are looking at two cohort of patients. The first one is the young patients, and the second cohort is the elderly patients. So for young patients, like we discussed earlier, we try to preserve all the native structures back to normal. So this is where all these stem cell, PRP stand for platelet-rich plasma. And these are the two treatments that are rehabilitative and also regenerative in nature, where it helps the joint structures to regrow back. Okay, so actually how they regrow back is by stimulating inflammation. So by stimulating inflammation, it recovers and regenerate the cartilage. Okay, so this is applicable for younger patients. Whereas for older patients, especially those 55 and above, this is actually not applicable because their metabolism has slower and the regenerative properties has been much lower compared to the younger populations. So that's why PRP, stem cells, prototherapy, all these are not very effective in elderly population. So we need to know how and what causes the problem in the first place, whether it's trauma or ACL tear, meniscus tear in younger patient, or cartilage wear, osteoartritis in elderly patients. So two different type of cohort patients require two different interventions. So just to answer your questions, yes, stem cells is effective, but only effective in certain patients where you have chosen it for those who are indicated and not just blanketly given to all the patients. And normally stem cell will not be effective in the elderly population.
Okay. So I know you still do quite a lot of research and journaling. Can you tell us a tiny bit more about the research that you're particularly interested in?
So I'm mainly involved in research where we are dealing with hip and knee diseases, specifically for knee diseases. So myself are one of the members of a group where we are analyzing the knee phenotypes as well as how robotic surgeries helps in terms of our patient recovery. And particularly, I'm interested and actively involved in analyzing how the different alignments affect the patient's outcome after the knee replacement. And from my initial results, we found that those who have undergone kinematic alignment, they perform better, especially in the short term. They have less pain, they recover faster, and they feel more natural after the surgery.
And looking 5 years ahead, what's coming in orthopedics that most patients don't know about yet? And what should people who are considering surgery today know about before they commit?
Actually, I'm quite hopeful about the future because of the advancement of technology. So recently, you have heard about the obesity treatment where they have this kind of injection and oral therapy to help with the obesity in terms of the weight control. So weight control is very important in this kind of population cohort where when you reduce the weight, it reduces the stress and forces transmitted through the hip and knee joint. So in that sense, it helps in terms of their recovery. In fact, some of them with osteoarthritis, they remains asymptomatic. That means they have no longer feeling pain after they have reduced the weight. Okay, so that's one thing which is quite promising. The other thing is in terms of the supplementation. So when we talk about supplements, a lot of people, they only focus on all this chondroitin and then glucosamines. Actually, these are all the building blocks for the cartilage regeneration, but actually they are not that helpful whenever the osteoarthritis already developed. But a lot of people don't know is what happened in the first place, what triggered the inflammation and what triggered the osteoarthritis in the first place. And early studies found that actually we do have some role in terms of the probiotics in our gut flora. So this one is still in the early stage, but now we are venturing into preventive medicine, where we are trying to prevent the osteoarthritis from happening. And early studies showed pointing towards this kind of gut flora and how probiotic avoid inflammation in the first place. So this one is, I think you can just put in, but just now when I talk about the partially, when we do surgeries, yeah, so these are the stages of osteoarthritis from grade 1, grade 3, grade 4. And then these are the difference in terms of total versus partial knee replacement. And for cartilage wear and tear, most of the time when we do the surgery, the wear is located on the inner side. The outer side cartilage remains intact. So that's why for this kind of patients, partially is indicated. So this is, and then how robotic systems helps in terms of our surgeries. We are able to get the accuracy up to 0.0 millimeter in terms of the bone cut, because how we do the bone cut actually determine where the implant sits in terms of the metallic implant. How it sits depends on how we cut the bone. Yeah. So if we are able to do it with a very accurate bone cut, then it reduces multiple trial of a bone cut, and that reduces a lot of soft tissue trauma. Okay. And then this is another example of partial knee replacement, where on an X-ray it shows maybe like grade 2 to grade 3, but actually when we do the surgery, we notice that the cartilage wear is almost grade 4, where the cartilage worn is almost total and up to the bare bone already. So that's why with this kind of cartilage wear, all the supplementation, pain medic control, and also injection will not help. And this is why we perform the partial knee replacement, where we replace the cartilage that has been worn off. Okay. Yeah. So actually, when I use robotic system to do my total knee replacement, I actually practices kinematic knee alignment. So what kinematic knee alignment is, we replace the knee joint based on the patient's native knee anatomy. So normally when we do total knee replacement, for conventional surgeons, normally they practice mechanical alignment technique. So what is the difference in terms of mechanical alignment and as well as the kinematic? So mechanical alignments, it restore the joint back into 90 degree, which is 90 degree at the thigh bone, 90 degree at the shin bone. So that, in that sense, you get a very straight knee. Whereas for kinematic knee alignment technique, we restore back based on the patient's native anatomy. So based on studies, we have found that 98% of the population, they do not have this what we call 90 degree knee alignment. So 98% of them, they have a bit of variation. So that's why after knee replacement, a lot of them, they have a lot of pain, and after the surgery, even though they are able to return to function, like walking up and down stairs, but they don't feel natural in terms of their knee movement. So by performing the kinematic knee alignment, we are able to get the patients to walk faster, able to reduce the pain after the surgery because of less tissue stretches. And after the surgery, normally they will feel more natural because we didn't alter the patient's native anatomy.
Dr. Kow, thank you very much. I came into this conversation with my knees in mind, and now I'm leaving with a much better understanding of what it means to do a knee surgery and what the next 20 years is going to look like for me. So for anyone who is listening who wants to learn more about Dr. Kow's work, he's at ALTY Orthopaedic Hospital in Kuala Lumpur. I'll link everything in the show notes. And if you took something away from today's conversation, if you're in that group of people who have been putting off a joint consult like myself, or researching surgeons for a family member, this is exactly what Medifly exists for. We don't match patients to hospitals, we match patients to the right surgeon for their specific case. And if that is you, come find us at medifly.ai. Thank you for listening. Until next time, don't forget to like, comment, and subscribe.